Okay. Hi, folks. This is John Adamson, the Rehab Documentation Guru, and today I'm pretty excited because I have a personal friend of mine and somebody that I've been wanting to get on a video call and upload it to my YouTube channel for your benefit. And I'd like to introduce you to Dr. Amanda Scott. Hi, Amanda.
Hi, everybody.
So, Amanda, what I'm going to be doing is explaining a little bit about your background. And one of the things you just need to know right off the bat is Amanda is what we would call in New England wicked smart. And I'm going to tell you about her wicked smart background in just a moment, and then you'll understand why she's on the call. So first of all, she's been in, and Amanda, please correct me if I'm wrong at any point here.
Okay.
So you've been an occupational therapist since 2000, and you also, since 2000, you earned a Master's in Business Administration from Purdue University. So
actually in progress.
Oh, it's in progress. Okay. Well, thank you for correcting me, but she's wicked smart in business already. She actually did earn her occupational therapy doctorate, OTD, in 2013 from Rocky Mountain University. And it's nice how instead of doing DPT, like you know, with OTD, or sorry, I should say, yeah, no, DOT. So if it was like DPT, it would be DOT, which then would be confused with Department of Transportation, which we would not want.
Right.
So anyway, she got her OTD, or doctorate, and we used to work together. And in the company that we used to work together in, she spent about 2.5 years as a modalities trainer. So she's got a lot of experience in that area. And then she spent about 10 years as an area clinical specialist, which is a position where you are providing guidance in the clinical realm for PT, OT, and speech. So she's got a lot of cross-disciplinary experience. She spent about 2.5 years as an assistant professor and residency coordinator for Huntington University's OTD program. And now she's taken on the role with Valparaiso University as being the program director for a transitional doctorate for occupational therapy. So did I get so far your work experience pretty good?
Yeah, you're doing great. Keep going.
Okay, I'm going to keep going because I'm going to continue to brag on you for a moment, and then we'll get to the nitty gritty of what we're going to talk about. Not only does she have all these degrees, but she has other letters after her name, as you'll see in the title of this YouTube video. She is board certified in gerontology by the AOTA. So this is analogous to the APTA's GCS. She also is a certified lymphedema therapist, and she's also certified as an Alzheimer's disease and dementia care trainer. So Amanda, you've got quite the experience load and quite the credentials, and I'm going to thank you for being on here because we're going to talk about something that I know that you can really speak to the OTs about that I might not be able to, and that is 97535. So first of all, Amanda, can you explain what 97535 is?
Sure. For those of us that have been around a while, it used to be called Adl Retraining. It's been since relabeled as self-care. So it's essentially kind of encompasses everything that we as OTs do regarding, you know, kind of essentially from the time you wake up in the morning to the time you go to bed at night. Whatever that daily routine is, it can be something as simple as bathing and dressing, but it can also encompass things like toileting, toilet transfers, and so on and so forth.
Excellent, excellent. And you know, sometimes therapists forget about the fullness of the meaning of that particular code. It's hard for some therapists to really define what the skills are behind the code. They'll document things like, you know, under skilled services, they'll say patient was mod assist for self-feeding, or min assist for lower body dressing. And they'll define how the patient did in the particular ADL, which might correlate with 97535. But could you help us understand what are the skills of an OT? What do they look like on documentation and behind the scenes related to 97535?
Sure. Common mistake is, like you were saying, you know, that they'll document, okay, patient was able to don shirt with mod assist. Okay, great. But what makes that an OT related activity versus, say, a nurse or a CNA or even a family caregiver putting the shirt on and saying, okay, yeah, they needed about 50% help. That's kind of the skill part that has gotten lost in the documentation when it comes to doing ADLs. So it needs to be more about breaking down those underlying impairments, right? It's more about our brains versus our hands when it comes to what makes me skilled, right? It's my clinical reasoning process, my ability to do that task breakdown. What element of that dressing required that 50% help? Was it due to shoulder or scapular immobility and decreased range of motion, or strength, or motor planning, or maybe it was a visual deficit, so they weren't able to tell the front from the back of the shirt? And what kind of cueing or compensatory strategies did you do in order to help that patient be able to succeed? It's those types of elements that are frequently missing in the documentation. And a lot of times, we just get in a hurry and, I just need to, slap something on the page so that way I can move on to my next patient. But we need to get better at actually diving into, okay, what really was that underlying cause on why they couldn't be independent with that? And what did I do or teach the patient to do, or adaptive equipment, in order to help compensate for that?
Excellent. What you mentioned, the fact that 97535 has to do with compensations, and a lot of therapists forget about the fact that we not only define functions, but we define underlying impairments. And one of the things I talk about in my documentation bootcamp course is that if you can't get to the root cause, the underlying impairment, you're really not demonstrating the skill of a therapist. And when you're addressing function, primarily our CPT codes are not directly addressing just the function in and of itself. They're addressing the underlying impairments, the things that are causing the functional deficits. I was wondering, and this is a little bit off the spot, but I know you're smart enough to handle this. Can you give us an example of like a compensatory strategy for an underlying impairment that's causing a functional deficit, and something that all OTs could, understand?
Sure. A really easy one that comes off the top of my head is, let's say you've got that patient that has a new total hip and they're on hip precautions. Our go-to as OTs is, long handled shoehorn, sock aid, reacher, right? You got to minimize that bending and breaking 90 at that hip flexion. So, a lot of times a lot of OTs will just give someone, the adaptive equipment, say the sock aid, and show them how to do it, and then that's kind of it. But there should be an education piece that goes along with that, right? Of not just, okay, this is how you use the sock aid to don and doff your sock, but why? Reinforcing those total hip precautions, talking about the cause and effect if you do break those hip precautions, and what are the consequences, and what if you accidentally break your hip precautions? What is it going to feel like? How do I, when should I call my physician? When should I not? So there's a lot more that goes into it that we just don't document. A lot of times we'll say trained with sock aid, or was min assist with sock aid for donning socks. But again, kind of looking at, okay, why? Why was that piece of equipment really needed in order to maximize the function of that particular task?
Right, because we talk about DME and assisted devices, and yet we just give them to patients, and sometimes the documentation doesn't really tell the story as to why we gave them that device. We've got to really be able to explain it with skilled terms, and that's something that sometimes therapists lack.
And especially, when you're working with the older adult population, it's very common that they're going to have a cognitive impairment on top of that new hip replacement, for instance. So what types of, whether it's forward chaining, backward chaining, chunking, what types of learning strategies did you do to help reinforce the use and the ability to use that piece of equipment as well? Mm-hmm. It's another thing that we commonly just kind of brush off to the side and just assume that, everyone's cognitively intact and can do this. And so maybe that patient can do that with you right there in that very moment. But, if you left for a half an hour and came back, would it have gotten enough into long-term memory that they could still remember how to safely use that piece of equipment? And a lot of times we're not checking on that. We're not going back and maybe doing that split session. Again, it doesn't have to take a long time, but just to make sure that they were able to retain that information. Or even just doing something like a simple cognitive screen, such as a SLUMS or a MOCA, just to kind of see where that patient is and how are they going to be able to carry over that particular strategy. Because if I'm creating a strategy that's too high level for them from a cognitive standpoint, they're not going to be successful, and I'm not going to get that good outcome. And then, of course, in our new world that we're going to be having here come October with PDPM and PDGM, we really have to show that patient outcome and that evidence-based practice side of it. So, really diving into, okay, what are the strengths? What can this patient do? And how do I capitalize on those strengths? It kind of goes back to my elevator definition of OT. We make you functional in your dysfunction. So how are you really breaking that down and teaching those different strategies, or teaching the caregiver those strategies for that matter?
Yeah, that's really a really good statement that you brought up, the elevator definition. This is totally an aside, but my wife, who you know is an OT, when she graduated from school, she got a t-shirt. It said, physical therapists show you how to get where you're going. Occupational therapists show you what to do when you get there. And I think that's probably a good scope differentiation that we need to keep in mind, and kind of goes along with what you're saying.
Yeah, definitely.
So this is a little bit off the topics that I sent to you, but you can definitely speak to it because of your strength in this area. One of the things that Medicare expects is that we document the patient's ability to learn new material. And because we are talking about 97535, which has a strong compensatory training component to it, what would you say to OTs in general about how low can a patient be cognitively before compensations just are not going to be their strength?
It varies patient to patient. A lot of times OTs are very familiar with the Allen cognitive levels. And so a lot of times we kind of say like that, level 3 on the Allen cognitive scale is kind of the cutoff. But just because someone has a cognitive impairment, we shouldn't just automatically discredit the ability to use a compensatory strategy. Because we do have folks that I kind of relate it back to the pediatric side of things of, splinter skills. There are certain things that still remain intact for that patient that has a cognitive impairment, regardless of the cause of that cognitive impairment. So they might be able to perform tasks that normally someone at that, say, level 3 on the ACL shouldn't and wouldn't be able to do, but they can. In our skilled nursing facilities, they're often nicknamed the Houdinis, where they're the escape artists. And you're like, okay, but this person, is scoring so low on a cognitive scale. How are they actually doing this? So they've just been able to retain that one element. So one of the things I think from a skilled side of OT is to look for those different elements that are still intact, and how can you incorporate that in to use with your compensatory strategy. And one of the things I like to do, especially from the ADL performance standpoint and strategies, is when I'm assessing someone, the first thing I ask them, in a polite manner, of course, is how old they are. So it gives me an idea of where they view themselves. If I have someone who's 85 years old and they're telling me that they're 35, well, that kind of clues me into where they're at mentally. So what types of roles and context are they thinking still they're in? And so how can I use that and that type of a routine in order to help teach and reinforce that compensatory strategy?
Excellent. You bring up some really important things that all point to the fact that we've got individual patients in front of us, and the new paradigm model of healthcare since the Affordable Care Act has really stressed the individuality of the patient care plan. And you talked also about the fact that cognitively, even though they might score a certain level, we got to keep in mind their life experiences and their particular strengths that individual patient might have that not all patients in that category would. You'd appreciate this. So I used to work in South Dakota, and we had a lot of Native Americans, I mean, true Native Americans. And, you had these little old ladies who used to live on the Indian reservation, who you'd give them the leather lacing from the ACLS-5, and they would ace it, and yet they were actually probably about mid-stage dementia. So it's just because of their life experience with doing all sorts of types of weaving and whatnot, it was no problem for them, and it wasn't truly representative of what their capabilities were.
Yeah, another great example is years ago, I had a speech therapist as a patient, and she had purposely practiced the slums and the mocha so many times so she could pass them, even though she was showing signs of cognitive impairment. So we had to get kind of sneaky with some of the different assessments we were administering, because it had to be something that she hadn't really seen before, because she had practiced them so much over the years that she could just ace them and fool you.
That's funny. That's funny. So we do have to be mindful of that. Sometimes our tests do not really show what the patient's truly at. And it could be just a particular patient bias. It could be that the test is not sensitive enough. And this is really a good segue into my next question for you. Because you've got a lot of experience in clinical education and you've taught therapists, therapy students, you're developing actually programs right now to teach potential transitional doctorate students. What are some of the standardized tests that you see that would really correlate very strongly with measuring true functional progress in the areas that are treated by 97535?
Sure. Kind of the gold standard go-to is the Barthel index for many folks, primarily because it's easy to administer, it's free, it's open source. So, that's kind of everyone's go-to, and it does have pretty strong psychometrics behind it. But the common misconception, I guess, is the best way to put it, when it comes to Barthel, is it gives you an idea of a standardized way of looking at how they're overall functioning, but it's not going to help you necessarily figure out what's causing the dysfunction, right? So that's where we need to do further testing with whether it's using clinical observation and noticing, they're having an abnormal movement pattern. Maybe they're, instead of doing shoulder flexion, they're doing circumduction in order to try and compensate. So what kind of specialty tests do I really need to dive into to look at the range of motion, the strength? Is there a muscle imbalance? Is there an old injury that never healed correctly? And looking at some of those different, orthopedic specialty tests, for example, to really dive into what is that root cause. Mm-hmm. The problem I think that most therapists face is that we look at, they've got a deficit in donning their shirt. And we kind of go to that easy strength, range of motion, and then that's it. Because I can do a quick manual muscle test, and a quick, eyeball measurement for range of motion. I rarely see therapists, especially, outside of outpatient, primarily, getting their hands on that goniometer and actually measuring the range of motion. I think it's a skill that we're starting to lose, especially like in long-term care. But we really need to have those definitive measurements to really discern, how much range is available and how can I compensate for it? Or can I restore that range? Because if it's not restorable, well, let's figure out the workaround. And then how do I train that compensatory strategy?
Right. Yeah, you bring up such an important point about standardized tests by themselves are not the end-all be-all of assessment, because one of the things we see in standardized tests is that they can be administered by multiple disciplines, so they don't necessarily make them discipline specific. And one of the things I've talked about in my videos and my course is the fact that we help define the necessity of our particular discipline by getting to the root cause, the underlying impairment, that assessment that very few professionals get to that level of depth of knowledge that we possess. That has to come through when we're interpreting the results from a standardized test. And I think that's so important.
Yeah, when I'm training new therapists, a lot of times I'll tell them, ask the question why 7 times. So if you get patient in front of you, right, it's standard, quality assurance types of root cause analysis, the patient's not able to live at home. Why? because they're no longer able to address why, right? It's taking that deeper dive. And by the time you get to that 5th or 7th why, well, now you've really gotten down to the heart of that underlying impairment.
Right.
So now when you start to address that underlying impairment, now you actually have a better shot of actually improving overall function.
Absolutely. Because one thing that I've seen, Amanda, like when I teach my course, and I've taught thousands of therapists across the nation, is I think a lot of them feel so pressured for time with productivity. They forget to do like what you're saying is take a moment and say why. Like keep on like interpreting and analyzing what's going on. And we get so stuck in a rut in terms of we got to treat this patient. Now we got to treat this patient. And we're not thinking critically through what's going on with that patient.
Well, one of the common reasons that I hear from folks is I don't have time.
Okay.
And I always chuckle at that because, okay, you don't have time for billable minutes. That's what you're telling me.
Right.
Because if anything, going through and doing that clinical reasoning and really doing that deep dive to really discern what exact underlying impairments are causing the dysfunction, what can I really do to treat it, that's the most skilled thing we can do as clinicians. So, you know, when I hear people say, oh, I don't have time, it just makes me chuckle because that's what should be in your documentation to justify your therapy minutes. Not just having them, you know, one of my big pet peeves is, you know, folks doing things like range of motion arches and pegboards when that's not clinically indicated, you know, for just something to fill up the time, so to speak. I see that a lot when I'm out in clinic. So, you know, it's taking that step back and going, okay, well, what's an actual worthwhile intervention that I can do with this person? And taking that, you know, 30 seconds, minute, 2 minutes, however long, that's all part of that skilled time.
Right. You know, therapists forget, and maybe they don't know, Medicare defines the skilled interventions as including periodic reassessments. So that reassessment of the efficacy of what you're doing is just part of what they expect you to bill. So why not take that time, like you said, because that's part of billable time, is truly assessing on an ongoing basis. Because if you don't, you're going to lack efficacy, you're not going to document well, and you're not going to get the outcomes you could possibly achieve if you're truly thinking through what the patient truly needs.
You know, a colleague of mine, I think, put it best. There's a difference between what's therapeutic and what's skilled. And, you know, so especially going back to 97535, okay, so that patient's dressing with mod assist. Is that therapeutic or is it skilled? Right? Me just helping them don or doff a shirt doesn't make it skilled. It might be therapeutic for the patient, but it's not skilled.
Right. That's
so it's kind of taking that deeper dive that I think where folks are kind of missing the boat on that and really going, okay, could I pull somebody, you know, Joe Blow off the street here? Could he do this? Could he rationalize through what's wrong, how to address it, and come up with that treatment plan or apply that treatment intervention? You know, if the answer is no, then it's skilled.
Excellent. Well, Amanda, you've definitely demonstrated something, and that's the importance of ongoing education of the therapist. And your university, Valparaiso, offers this transitional deep OTD program online. Is that correct?
Yeah. Actually, I've designed it for that working OT. So you take one class at a time. Each class is 7 weeks long. So it takes approximately 2 years to complete, but you're able to actually maintain that work-life balance throughout the program.
So if you want to be as wicked smart as, you know, Amanda is demonstrating here, you want to get some good education, which, you know, is coming right from her, and I'm sure other professors that she's going to be hiring as she develops this program. You want to check out Valparaiso. So how can they get in touch with your particular program?
Well, they can check out our website at valpo.edu/occupational therapy, and all of my contact info is right there on the webpage. And I'm more than happy to chat with anyone, whether by phone or email. and answer any questions that they might have about the program.
And is there a way that people might be able to just touch base with you if they want after this particular video? Would you be comfortable with them having some contact information with you?
Sure. The easiest way to get hold of me is through email. And so it's amanda.scott@valpo.edu. And again, you can also go to valpo.edu's website and find all my contact info on there and just send me a message right through the website.
Great. Well, thank you, Amanda.
Thanks, John.
Dr. Amanda Scott, showing why she's wicked smart, and also demonstrating why she's my second favorite OT after my wife. So anyway, this has been John Adamson, the Rehab Documentation Guru, inviting you to document better according to 97535 and demonstrate the skills of a therapist that show that you should get paid for what you do. Thank you for watching. God bless. Please leave some comments, and I'll talk to you later.